Welcome to Pathology Central Key Concepts. The topic of this video is cardiomyopathy, and as such we have one objective and one objective only: compare and contrast the different types of cardiomyopathy. What is a cardiomyopathy? It's cardiac disease due to intrinsic myocardial dysfunction. Now, there are a lot of cardiac diseases due to intrinsic myocardial dysfunction. So for this definition, we are going to exclude a set of diseases with particular clinical and pathophysiologic contexts, such as coronary artery disease, hypertension, valvular disease, and congenital heart disease. And once we do that, what we are left with are the cardiomyopathies. Now, they may be primary or secondary, and there are a variety of different causes. So they may be hereditary due to inflammation, such as myocarditis, immune dysfunction, sarcoidosis, or metabolic derangements such as hemochromatosis. There are a variety of different ways we can classify the cardiomyopathies. The one that we will use in this video, and which is used in Robbins, is to look at three clinical, functional, pathologic patterns: dilated cardiomyopathy, which is the most common at about 90%, hypertrophic cardiomyopathy, and restrictive cardiomyopathy, which is the least common. Let's look with a little bit more detail at each of these types. In dilated cardiomyopathy, you get progressive four-chamber cardiac dilation. So the heart is going to begin to expand and dilate. As it does that, you're going to have decreased contractile function, right? Because the walls are going to be becoming thinner and the volume in the chambers is expanded. This is going to stimulate the heart to undergo myocyte hypertrophy. But the end result is going to be a flabby, floppy heart. Arrhythmogenic right ventricular cardiomyopathy is a subtype that we'll talk about later. Now, in contrast to the systolic dysfunction that we see in dilated cardiomyopathy, in hypertrophic cardiomyopathy, we have diastolic dysfunction. And in contrast to the flabby, floppy heart of dilated cardiomyopathy, in hypertrophic cardiomyopathy, we have a thick-walled, heavy, hypercontractile heart with myocardial hypertrophy. But this thickened wall is going to prevent the chambers from being able to dilate appropriately. They can't fill with blood to the extent that the body needs, and we have defective diastolic filling. About a third of these patients have ventricular outflow obstruction. Now, similar to hypertrophic cardiomyopathy, restrictive cardiomyopathy is also a problem of impaired diastolic ventricular filling. But in this case, it's not because the walls are thick, it's because they are stiff. And this is a primary decrease in ventricular compliance, and this will be due to some sort of interstitial process like fibrosis or amyloidosis. This figure from Robbins and Kumar, Basic Pathology 11th edition, nicely summarizes the findings. So here on the left, we have a happy, healthy heart. So you can see the relative dimensions of the atria and ventricles. And let's compare that to our dilated cardiomyopathy heart here, where you can see that the wall thickness is pretty much the same as what we see in the healthy heart. And this can be, as we progress along the spectrum, as we start to dilate, the walls may begin to thin, but we're going to undergo cardiac myocyte hypertrophy, so it will thicken. And at this point, this has not reached that full, very thin dilation that you can see in end-stage dilated cardiomyopathy. But what you can appreciate here is that all four chambers are markedly dilated. In contrast, what we see in hypertrophic cardiomyopathy is that only the left atrium is dilated. But what's first going to catch our eye, of course, is going to be this incredible hypertrophy of the heart walls, which is most prominent here in the left ventricle. But even more noticeable than that is going to be the interventricular septum. Even when you get left ventricular hypertrophy in the context of hypertensive disease, that's going to be concentric, and you don't see this asymmetric thickening of the interventricular septum. Now, the left ventricle is the one that's most affected by having this hypertrophy, and the chamber is going to adopt this banana shape as the interventricular septum bulges in. The chamber is not able to dilate fully because of the thickness of these walls. This is going to lead to pressure pushing back on the left atrium, which will become volume overloaded and will dilate, which can lead to atrial fibrillation and mural thrombi. Now finally, as we look at restrictive cardiomyopathy, we can see that the walls may be a little bit thicker here, but the primary finding here is going to be dilation of both atria. That's because both of the ventricular chambers are going to be very stiff. And so blood once more cannot fully empty from the atria. Some will be, there'll be residual blood here, pressure backing up, and then we end up with our atrial dilation and the potential for atrial fibrillation and mural thrombi. So what is the effect this has on the patient? In order to get an idea of that, we're going to consider left ventricular ejection fraction. And you'll remember that means the amount of blood, or the percent of blood, that is ejected from the heart, from the left ventricle in systole. So what we see in dilated cardiomyopathy is that the left ventricular ejection fraction is less than 40%. And the range of normal values is about 50 to 65%. So it's significantly decreased. Why is this? So keep in mind, you now have a much larger volume because you've dilated that ventricle. And so as you push against it, there's going to be less blood that can move out because there's so much in there. It's not as, you don't get as much systolic function. Furthermore, the muscle that's pushing against it is going to be weaker and not as strong as the healthy heart. Now, in hypertrophic cardiomyopathy, as I mentioned, you have hypercontractility, you have a very muscular heart, and you also, once more, are going to have a smaller chamber. So greater force, smaller volume, increased left ventricular ejection fraction. What we see in restrictive cardiomyopathy is similar in that we have normal cardiac contractility, but we're going to have decreased volume in our chamber. So once more, left ventricular ejection fraction will be higher. But although in both hypertrophic and restrictive cardiomyopathy, even though we have a good percentage, we're not getting the right volume because in both of those instances, the chambers are smaller. We'll be discussing mechanisms and causes in subsequent slides. It is worth being aware of the secondary causes of myocardial dysfunction that mimic these cardiomyopathies because the cardiomyopathies are a diagnosis of exclusion. So let's look first at dilated cardiomyopathy. About 20 to 50% of them are inherited, and we'll go over the genes and proteins on the next slide. Infection is another cause of dilated cardiomyopathy, and this is a list of some of the viruses that are associated with dilated cardiomyopathy. We also know that alcohol and toxins can cause dilated cardiomyopathy. So in chronic alcohol use disorder, patients may present with dilated cardiomyopathy. We can also see that with some chemotherapeutic drugs such as doxorubicin, as well as with toxins such as cobalt and arsenic. Now, cobalt and arsenic excess are not very common, and even less common would be selenium deficiency, but these are potential contributors to this disease. Now, something that is an important consideration is peripartum dilated cardiomyopathy. It's seen in late pregnancy to early postpartum period and occurs in about 1 to every 1,000 to 4,000 live births. And when you consider the number of live births every year in the country, you can see that there will be a significant number of patients who may be facing this diagnosis. We're not sure the exact etiology. It's probably a combination of factors, including pregnancy-associated hypertension, volume overload of pregnancy, nutritional deficiency, metabolic derangements like gestational diabetes, and or immunologic responses. And all of these can contribute to impaired myocardial angiogenesis, which will lead to ischemic injury, which will then lead to dilation. And finally, we need to be aware of iron overload, which we can see in hereditary hemochromatosis or secondary to transfusions, which we're given because of anemia. Now, I mentioned the genetic causes of dilated cardiomyopathy. So as I said, about 20 to 50% of cases are inherited. More than 50 genes have been implicated, and the pattern of inheritance is usually autosomal dominant, with one notable exception. And what we see in dilated cardiomyopathy are loss of function mutations in cytoskeletal proteins and proteins that link the sarcomere to the cytoskeleton. So the big three for this will be beta-myosin heavy chain, cardiac troponin T, and titin. And of those three, titin is the most common. Now, the one X-linked gene that we see mutated in dilated cardiomyopathy is dystrophin. So you will see dystrophin mutations in that particular subset. And something to keep in mind is that when we're looking at loss of function mutations in these particular genes, we can also see that these same genes are mutated in hypertrophic cardiomyopathy, but instead of loss of function, we get gain of function. We'll talk more about that in a moment. So let's take a look at this really nice figure of a cardiac myocyte. We have our extracellular matrix in which the dystrophin-associated glycoproteins are going to anchor here. We have dystrophin attached by Desmond to our actin filaments here in green. We have our myosin here in red. myosin binding protein here. We have our Z discs, and spanning that is the protein titin. Now, in red are the genes that are mutated in dilated cardiomyopathy. So we already talked about dystrophin and desmin, which is an intermediate filament. Lamin AC and titin are the four that are mutated in dilated cardiomyopathy alone. But there, as I mentioned, there are a subset of genes that are also mutated in both dilated cardiomyopathy and hypertrophic cardiomyopathy. And those are here in green. So we have actin, troponin T, and beta-myosin heavy chain. All right. So what are we going to see morphologically? Grossly, the heart is going to be enlarged about 2 to 3 times normal weight and significantly enlarged because of this 4-chamber dilation. As I mentioned, the ventricular wall may be normal thickness, thinned, or thickened, depending on where you are in the progression of the disease. Because of this 4-chamber dilation, you'll have areas of stasis, which can lead to mural thrombi. Microscopically, the findings are somewhat nonspecific. You can see myocyte hypertrophy, or they may be thinned or attenuated, again, depending on where you are in the progression of the disease. There will be variable interstitial to endocardial fibrosis, and in the dilated cardiomyopathy secondary to titin, you can see titin mutations, you can see stellate nuclei. So let's take a look. Here we have a beautiful image of dilated cardiomyopathy with a vastly enlarged left ventricle, left atrium, right ventricle, and right atrium. As I mentioned, because you're getting ineffective pumping, so we only have about a 40% ejection fraction, that means there are going to be areas of stasis. And here you can see a mural thrombus right down here in the ventricle. Histologically, we'll see this interstitial fibrosis. This is a Masson trichrome stain, so muscles in red, fibrosis is in blue. And then just so you can say you've seen it once, here is a nice image of dilated cardiomyopathy secondary to titin mutation with these stellate appearing nuclei. All right, before we leave the dilated cardiomyopathies, we need to focus on arrhythmogenic right ventricular cardiomyopathy because it's seen in about 1 to 2,000 and 5,000 in the general adult population, but significantly we see it in about 10% of athletes who die from sudden cardiac death. And this is due to right-sided heart failure and rhythm disturbances, and we think that perhaps this is due to desmosomal detachment. The reason we think so is because this autosomal dominant disease is typically due to genes that encode desmosomal junctional proteins at the intercalated disc or proteins that bind to the desmosome. What we'll see morphologically will be thinning of the right ventricular wall, replacement with fat, and a bit of fibrosis. Now let's take a look at this image here. So previously we looked at our sarcomere with our dystrophin and our glycoprotein complex, our nucleus hanging out here. But right now we're going to focus on the desmosome attaching these two myocytes. And here you can see a blow-up of that particular area. And each of these proteins has actually been found to be mutated in this particular disease. So this is where you can imagine if these fail, you're going to get splitting apart of these cells, which can lead to catastrophic sudden cardiac death. So here's a gross image. You can see this profoundly dilated right ventricle with mostly fibrosis here. We don't see a lot of fat here in the wall. This left ventricle looks perhaps a little bit hypertrophic. You can sometimes see some changes in the left ventricular wall as well. Microscopically, again, a Masson trichrome stain with the muscle in red, fibrosis in blue, and then we have this fatty replacement as well. All right, this brings us to our next entity, hypertrophic cardiomyopathy, and all of these are hereditary. So they're all due to genetic causes, typically due to missense mutations in genes that encode proteins that are part of the contractile apparatus. So far we've identified about 9 genes with more than 400 mutations, and almost all of these are autosomal dominant mutations. What we see are gain-of-function mutations that affect the sarcomeric proteins. So of those, beta-myosin heavy chain, myosin binding protein C, and troponin T are going to account for 70 to 80% of cases of hypertrophic cardiomyopathy. What these gain-of-function mutations will do will be to increase myofilament function, which is going to increase myocyte hypercontractility, increase energy use, and lead to a negative energy balance as we're contracting far too much with far too much energy. Now, as I mentioned, some of these same proteins are affected in dilated cardiomyopathy, but in hypertrophic cardiomyopathy, we have an increase in motor function, while in dilated cardiomyopathy, we have a decrease in motor function. All right, let's go back to our image, and now we look at our hypertrophic cardiomyopathy. I've circled in red the big three: troponin T, beta-myosin heavy chain, and myosin-binding protein C. One that is unique to hypertrophic cardiomyopathy is myosin light chain. You don't see that in dilated cardiomyopathy. All right, so let's go on to talk about what it is we're going to see, because this has a very impressive appearance. So we're going to see massive myocardial hypertrophy without ventricular dilation. So what we can see in left ventricular hypertrophy due to systemic hypertension will be that we'll initially get that concentric hypertrophy, and at a certain point the heart's going to start to fail and it will dilate. Okay, so this is one of the mimics of dilated cardiomyopathy, but we don't get ventricular dilation in hypertrophic cardiomyopathy. We also will see an asymmetric septal hypertrophy, which is going to lead to what I discussed before, the banana-like cavity. Now, because of this asymmetric thickening of the septum, we can get striking of the anterior mitral valve leaflet against the septum, which could cause a fibrous plaque at the left ventricular outflow tract and thickening of the mitral leaflet. And microscopically, we have some pathognomonic findings. The myocyte hypertrophy is something we can see in other etiologies, so don't focus on that. But the haphazard myocyte myofiber disarray is classic, so we'll look at that in a moment. You can also see fibrotic narrowing of the small intramural arteries and interstitial and replacement fibrosis. So this is a pathognomonic image. If you see this, you know what it is. You start looking at your answer list to start figuring out which protein is mutated if you see this on a board exam or a shelf exam, because these are the classic findings of hypertrophic cardiomyopathy. So we see this massive thickening of the left ventricular wall. We also have thickening here of the right ventricular wall. But look at the septum. It's like this gigantic egg shape that's bulging into the left ventricle. Here's that banana shape we were talking about. And you can get some fibrosis here where the mitral valve leaflet strikes it. Now, because we have this massive thickening, this chamber can't dilate, right? So it can't open up to receive the blood, and we end up with a volume overload here in the left atrium, which will have to then dilate, which can lead to atrial fibrillation and mural thrombi. This microscopic image is also pathognomonic for this disease. Instead of the nice parallel arrays of cardiac myocytes, which are going to lead to effective contractility, we see this haphazard array. Some look branched and stellate, sort of a meshwork of cardiac myocytes. Now, before we leave this disease entirely, let's do a quick compare and contrast of dilated cardiomyopathy and hypertrophic cardiomyopathy. Keep in mind that for hypertrophic cardiomyopathy, 100% genetic causes typically are sarcomeric proteins, that contractile apparatus. In contrast, in dilated cardiomyopathy, about 20 to 50% are genetic, and there are a variety of causes. They're going to have different effects, so defect in energy transfer leading to, and we can also get direct sarcomeric dysfunction. This is the phenotype we just described. Here is the phenotype that we see in dilated cardiomyopathy, but both of them may have the same end product: heart failure, sudden death, atrial fibrillation, and stroke. Okay, so this brings us to our last entity, restrictive cardiomyopathy, which, as I said, is the most rare. It can be idiopathic or associated with systemic disease such as amyloidosis, sarcoidosis, or metabolic disease such as a glycogenosis, in which you have storage, Gaucher disease, you have storage in various cells of byproducts. So if we look at the big three in restrictive cardiomyopathy, the things you need to think about or associate with restrictive cardiomyopathy, number one is amyloidosis. And you'll be thinking about this in the context of multiple myeloma. And in this case, patients who have multiple myeloma who develop cardiac amyloidosis have a double whammy, because not only do they have the amyloidosis, which is going to make the ventricle wall thick, but the immunoglobulin light chains are cardiotoxic, so it's going to cause some dysfunction of those myocytes. Another type of amyloidosis we can see in the heart is when we have transthyretin deposition. And this can be a wild type, as we see in systemic amyloidosis, or it can be mutated. And this is an allele which is relatively more common. It's seen in about 4% of African Americans. It is thought to have originated in Western Africa. Which is the origination of many of their descendants of chattel slavery here in the United States. Another entity to consider for restrictive cardiomyopathy is endomyocardial fibrosis. It's not something you will typically see in the United States unless you are seeing people from an immigrant population. However, it's the most common cause of restrictive cardiomyopathy worldwide, and it's primarily seen in tropical climates in countries that are of lower income. And it will primarily affect children and young adults. So this should be something you should be thinking about if you have an immigrant, child, young adult with cardiac symptoms. Now, we don't know the etiology, but there are some suggestions that have been made. So it may be due to nutrient deficiencies. Some have suggested it may be due to a diet rich in cassava or plantain. And then inflammation is also close to the top of the list of potential etiologies because a lot of these areas are endemic for helminthic infections, and this can cause eosinophils to accumulate, and I'll tell you a little bit more about that in a moment. So what we typically will see will be dense diffuse fibrosis of the ventricular endo and subendocardium, as well as of the tricuspid and mitral valves. Now, I mentioned the eosinophils that are associated with helminths. We also see eosinophils and Loeffler endomyocarditis, but unlike endomyocardial fibrosis, it does not have a geographic distribution. It does have a peripheral hypereosinophilia, so increased eosinophils in the peripheral blood, and biopsies of the heart will show eosinophilic infiltrates. It's associated with endocardial fibrosis and mural thrombi. So let's take a look at these three entities, beginning with amyloidosis. This is just a beautiful image showing cardiac myocytes that are just enveloped and embedded in this extracellular protein. You notice it has this glassy pink uniform appearance that is classic for amyloid. If we go ahead and do a Congo red stain, we'll get the apple green birefringence, which will take us home on this one. We could also do immunohistochemical stains for light chains or for transthyretin. This is an image of endomyocardial fibrosis that we see in patients, typically, as I mentioned, from poorer countries so lower resource countries and tropical areas. And you can see here we have this endocardial fibrosis. It's really quite prominent and in the subendocardial region. So this is a particularly interesting case. It comes from a case report. This was diagnosed in a 9-year-old child who came from an area in India where filariasis was endemic. And actually, when she was 3.5 years old, she presented to the physician, and they noted at the time that she had peripheral eosinophilia. And it was thought at the time that perhaps this was due to filariasis. There were other people in her family who had this disease, but she received no treatment, and then about 6 years later presented with these cardiac findings. So this may be something to consider. Finally, let's take a look at Loeffler's endomyocarditis. You can see here a beautiful example of eosinophils, my personal favorite cell because they look like little red sunburned faces with sunglasses on. And we see some here in the subendocardial area as well. So here are these eosinophils. What's the problem with them? It's not just the fact that they're there, it is what they are doing. So here's a beautiful example of immunofluorescence for eosin major basic protein. So you can see the little green dots are intact eosinophils, but the smeared area here is going to be where we see that the granules have ruptured out into the tissue. Now we have these mediators that are going to contribute to fibrosis. Fibrosis, which we see here at this end stage of Loeffler endomyocarditis, at which point the inflammation is now gone, but all we have left is the residual fibrosis, shown once more with a Masson trichrome stain, red for the muscle and blue for the fibrosis. Finally, this brings us to our questions. So these are to help you review the information that you've learned in the last 25 minutes. If you can't answer them by reading this, go back and watch the video again. As always, thank you for your time and attention. I appreciate your comments, and feel free to reach out to me. Have a great day.